Yes.
Awesome, awesome. Then what I'll do is I'll slip into presentation mode. So anyway, hi there. I am, as you said, Seth, Sean Bush, and it's nice to see y'all on the Zoom. So I can never get used to this format. I was just on a live format last week, and I was spoiled. It was really fun to be able to speak to a live audience. So anyway, that being said, I'm gonna go ahead and tell you what I know. I like to talk about things I know. And so I kind of keep my talk, I kind of limit it to what I've had experience with. And and what I've had experience with is, and also I know this is a wilderness medicine group. And so I'm going to be speaking to y'all from that perspective. We're going to talk mostly about wilderness management and a little bit about medical management. If y'all ask me some questions about medical management, we can go into more details about that. But what I know about and what I've experienced is I know how to treat snake bites in California, kind of Australia, a little in Africa, a lot in North Carolina. And the title of my talk is From Venom ER to Copperhead Country and on to venom death zones around the world. And first of all, I like to talk a little bit about, well, first of all, I wanted to mention some current events, and I noticed there was a space launch yesterday. William Shatner, Captain Kirk went up in space. I was excited for him. I was a big Star Trek fan growing up, and I noticed something, that all the space launch sites are in snakebite country, like they dropped that spacecraft down right in West Texas, where I used to find all kinds of rattlesnakes, and I can just see Captain Kirk stepping out and stepping on a rattlesnake. I think that maybe some of these space billionaires need to send some money our way so that we can go and study this out in snakebite country. And speaking of snakebite country, this is where I am now. This is a road, right? I walk on this road every day. And I do wish every road was named Copperhead, kind of like the song talks about. And this is just a copperhead crawling across the road where I walk my dog almost every day. And I love these snakes. They're such cool snakes. And if we have some time, we'll do a little copperhead wrangling at the end of the show. Yeah, they're a tough enough snake to cause some injuries. But this is where I live. I'm in North Carolina right now. And the song continues to go on, and I wish grandpa's never died, and I wish this too. My grandfather was the one that got me started on snakes. Here he is back in Texas with a Texas rat snake, and he had all kinds of cool animals and wildlife. He had snakes and owls and raccoons and all these cool critters in his backyard. And that is what got me started on science and nature and ultimately medicine, as I started to kind of follow my journey with following snakes and snakes around the world. Basically, that's my grandfather. When I was about 5 years old, he gave me a venomous snake, and that started me on this journey. And there I am over my grandparents' house, holding a venomous snake in my hands there. I got a constrictor around my neck. It's kind of tough growing up in Texas back in those days, when I was young. That's about 50 years ago. And as I grew, I started to, find, that's a California king snake that I brought back to Texas from California. That's out in West Texas, where they're launching Blue Origin. And then, of course, my grandmother also influenced me very heavily, and my father too, because they were nurses. And so I was kind of interested in snakes, but I was also interested in medicine. And so what I did was I studied both. I studied snake bites in medicine, and it's kind of an easy thing to study because snake bite, especially where I've practiced, is an emergency medical condition. And that's a publicity shot right out of Venom ER, where where I'm just fascinated by the snake bites that we would see. And this kid had a really bad snake bite. He's up in that one's up in the PICU. But this one was in the ER, and she came in with a Mojave rattlesnake bite. And we actually were filming at this time. This is a screenshot, a frame grab from our television show called Venom ER, which is now, I mean, it was on the BBC and what used to be called Animal Planet, and now it's on YouTube. So if you ever want to look it up, just look up Venom ER. You have to spell it funny because it was produced by the BBC. But this little girl came in with a really bad Mojave rattlesnake bite, and we gave her anti-venom, and she reversed pretty miraculously. It was pretty amazing. And so I saw lots of cases like that. And there it is. There's the YouTube thing. It's called Venom ER. If you're interested in seeing some more videos, and if I have time, I'll show you a video at the end of this talk. And of course, it was recognized. My work was recognized by the White House Medical Unit, and then, you know, here I am today, still with the venomous snake. It's a hognose snake. In case you were wondering what kind of venomous snake my grandfather gave me, and that's a hognose snake too. So anyway, now, you know, my life wasn't all just like, you know, doing my job on television while the president watched. At some point, I had some tough things happen to me, and there's when my son was bitten by a venomous snake in our backyard when he was about 2, and my neighbor's Ed Domain is over there like helping him to the helicopters that I used to kind of ride along with, and he has a couple of fang puncture marks, and you can see where we've marked to the advancing tenderness up his arm. That's my son there. And he, you know, having a snake bite and having to be in the ER, it kind of sucks a little bit. There he is. He's not having that much fun, but he did well. He ultimately did well, and he's been a good sport about it. We actually we reenacted it for Untold Stories of the ER, and I think that helped us process it more than anything. And I don't know if he really remembers the bite as much as he remembers the reenactment, because we kind of had fun with that. And you know, he was, like I said, he's a good sport. Here he is with a copperhead. I'm sorry. Here he is with a hognose snake, and later on, you know, he also had a constrictor around his neck. You know, so this whole sort of family sort of tendency perpetuated. And he shows snakes with me. He comes to my snake talks, and we educate folks about snakes and snake bites, and my daughter does too. Here she is down in Australia with I think that's a carpet python, and we were down there, and then of course she grew up to be very interested in snakes. I got her a corn snake, and she also helps me show snakes. You know, I mean, you can see I got a hog nose in one hand, a copperhead in the other. She's got her corn snake, and we're out there preaching the snake gospel, not like church people, but just talking about snakes and snake bites, like what I'm going to talk about today. So what I did basically to combine my love for snakes and medicine is I kind of did both. I graduated at the top of my class. I mean, quite literally, there I am at the very back of my class. I don't know. I think I'm right there. That's me. Anyway, I don't know how I stopped doing that now. Oh, here we go. I went to Texas A&M. Now I have to get this off. It's going to be on there the whole time. So sorry about that. Well, next time I won't do that. So anyway, I went to here we go. So I went to Texas A&M for undergraduate. Then I wound up in California. I ranked a lot of places. You know, I ranked North Carolina and Southern California, or I ranked California, and I ended up in California. And I like, because, you know, in the Carolinas, we got copperheads, and in California, we got buzztails. I think that's where we get that, right? I think it's also another country song. So I ended up in California. There's a bunch of Mojaves out there. We also had rattlesnakes. That's a Western diamondback. We had speckles, red diamonds, and we used that as art on the cover of the book we edited from one of our symposiums. And of course, there's this one, the Southern Pacific rattlesnake, which bit a lot of people there in Southern California. So people would bring snakes into my emergency department. I was excited to be able to bring a snake hook to the emergency department to work with me. Sometimes I got to use it. It was real cool. And I treated, this was like one of my first cases as an intern, as a first-year resident. I treated this 7-year-old boy who had so many complications from snake bite. I mean, he was bitten. He got like Wyeth's anti-venom crotalidate polyvalent and had a really bad anaphylactic reaction to that. And we had to keep treating him because he had a really bad envenomation. He got rhabdomyolysis and hypocalcemic tetany and all these complications. It was really amazing. And this was part of what fascinated me about snake bites is it affected so many systems. And so I found that I could probably study that my whole career. And it has been something that I've been studying my whole career. This was 29 years ago when I treated that kid. And now it's almost been 30 years and I'm still doing snake bites. So really what I want to tell y'all in this presentation, besides talking about myself, is I want to tell you, here's a few medical messages that I think that you should carry with you. And the first message is anti-venom is the treatment for serious snake envenomation. Everything else that might be tried, it's either temporizing or adjuvant, maybe it doesn't work, but anti-venom is the treatment for serious snake envenomation. I like to say time is tissue. And by that, I mean that, when snake venom gets injected underneath, something that the snake wants to eat, it starts to digest it. But when it gets injected into you or your patient, it starts to digest you. And that's not so good. And you can't reverse digestion. So you have to stop it and then you have to heal from it. And the quicker you do that, the quicker you'll have a better outcome. So time is tissue, right? And snake bite is actually a really good reason in the United States to call 911. It's a medical emergency. And of course, the sooner you get this anti-venom going, the sooner you get to the hospital, you can sort out what's going on and take care of your patient or take care of yourself, whatever, depending on who's bitten. Snake bite is a good time to talk to consultants. Good consultants like are available through the American Association of Poison Control Centers, experts like myself and some of my colleagues. There's people out there that, and there's an algorithm we developed too collectively. Some of my colleagues like Eric Lavonis and Spence Green, and there's actually some other good places to get good expert advice, and of course, do no harm. That's something that we take an oath in medicine not to do. Is we don't want to harm our patient. We don't want to do anything that causes harm to our patient. We always talk about risks and benefits and alternatives. And a lot of the things that have been tried for snake bite cause more harm than good, or sometimes they cause harm and no good. So we'll talk about that some more too. And the things that reduce morbidity and mortality in the United States include modalities like rapid transport, state-of-the-art emergency and intensive care, and of course, good anti-venom. In the United States, very few people die from snake bites. In fact, there's fewer than half a dozen deaths per year on average reported to American Association of Poison Control Centers, and some of the best available estimates of mortality. Not that many deaths from snake bites. In fact, more people are killed by all these other things like bee stings and horse injuries and hitting a deer, and of course, dog attacks, lightning strikes, the flu, COVID, for crying out loud, but not shark attacks. But what is common is a loss of function. And here's what happens. Here's kind of a sequence of how venomous bites cause injury. So in the top frames, you can see the patient was bitten by a red diamond rattlesnake, and the fang penetrated the proximal interphalangeal joint of the middle finger. And you can kind of see the puncture, and there's bruising and some bleeding from there. And then on the bottom frames, the one that looks kind of yellowish, that's like 6 or 7 weeks later. And you can see how that tissue that was injured has sloughed away. And then years later, he came back in the other bottom frame, and you can see he can't extend his finger because he has long-term injury to that. And that's actually, I don't know, that's pretty common. It's much more common than death after snake bite. And of course, there's lymphatic injury. And of course, here's a person that's got a lot of lymphatic injury, and snake bite, a lot of it will track up the lymphatics because it causes, and then it causes that, increased vascular permeability, and it leaks out of the vasculature and the lymphatics, and it causes destruction all around. And where it causes destruction, sometimes that doesn't bounce back, especially when you get a little bit older and your lymphatics are not quite as resilient. And then you could get problems like dependent edema when you stand up for a long time, like working, like in the OR, or standing up giving a lecture, or whatever you do that requires you to stand up. And of course, sometimes people lose their finger or their toe or their thumb from a snake bite. So I said first do no harm, and of course first aid should do no harm. We don't want to add insult to injury, and things that are not recommended first aid for snake bite include all these things like cutting and sucking and tourniquets, electric shock, and placing ice directly on the wound. And so this is one thing that used to be advocated by the Wilderness Medical Society as something that could be used for snake bite. And this was one of the first things I set out to study back when I was a young junior faculty. And, the thing was, it was a device that didn't require cutting. I mean, a lot of people would buy into like, well, you shouldn't cut, a layperson shouldn't cut across a snake bite wound and try to suck out the venom. So, but this thing only, it was just a suction device. It didn't do any cutting. So what we determined after doing a series of studies and researching the literature is that the extractor only removed minute quantities of venom. And by minute, I mean 1/10,000th of the amount of venom that was introduced. And it can cause an injury pattern. And this is what the injury pattern that showed up in the animal model that I used, which is a pig model. And these pigs went on to heal, but some of them with the extractor wound had complications. It took them longer to heal. Some of them had gotten wound infections because of that lesion. And of course, similar lesions have been seen in humans. And so after doing the studies and assessing the evidence, I wrote an editorial for Annals of Emergency Medicine that pretty much summarizes snakebite suction devices don't remove venom, they just suck. And people still like that title for the paper. But that was one thing that I studied. I also went on to study pressure mobilization. So in Australia, they have this technique where they basically wrap the extremity with something like an ACE wrap or a crepe bandage, and they splint the extremity, as tight as you would for like a sprain. I mean, it's not like a tourniquet, and then you immobilize the extremity, right? That's what you do in Australia because the snakes there, they cause a lot of systemic toxicity. They tend to cause less local symptoms in terms of unlike the pit vipers in the United States, right? And so it'd be really easy to have like a SAM splint, this and a couple of ACE wraps in your backpack. It would be kind of it's something that is cool if you're backpacking across Australia to maybe pack some of that because it could save your life. It definitely delays mortality. It buys you some time to get to medical care if you're out in the wilderness in Australia after an Australian elapid bite. and so it really does sequester the venom and slow the spread. But, pit viper venom digests. So I did this study with the same sort of model with the pigs, and we did find that it delayed fatal bites. It delayed mortality, but it also did things like increase compartment pressure, and I published that. So there's a lot of considerations. Pressure mobilization is not recommended in the United States because most of the bites are due to pit vipers. There may be certain circumstances where it could be beneficial, like an eastern coral snake bite. There's a Mojave from Southern California, which they tend to be more neurotoxic with less local symptoms. And then, of course, there's an eastern coral snake bite. And then there's other things that haven't been studied thoroughly. And I think that there's this whole, you might have seen this out there. If you have, I want to address it briefly. I think that so far, my criticism of this device is I think it's likely to increase local injury similar to the lesion associated with the extractor. And the studies done by the person that developed them did not assess local injury. And they were studied on pig torsos and coral snakes, and most bites are not on torsos by coral snakes, and so that's going to limit the external validity of the studies that were done to develop this device. And of course, the actual device wasn't even studied in the studies that were used to develop it. It's very unwieldy. It's hard to put it anywhere but the torso or a flat portion of an extremity, and it can't even really be applied to most bites. I would like to study it a little more definitively. I mean, there may be a place for it. I don't know. I was trying to think if you were bitten on the torso, so when I was in Africa, people would take mamba bites to the head, neck, and torso, because the mambas would be cruising around through the sugarcane at like head and neck level. And people died fast after a bite like that. I mean, maybe it could be used for that. I think it could be studied, but I've been having a hard time coming up with a good design. I don't know. I wouldn't recommend it until it was better studied for right now. In terms of electric shock, that was recommended or advocated for a little while, but no form of electricity has been shown to be effective, and that should not come as much of a shock to people. And there's a lot of injury potential, and currently it's not recommended. I think probably so snake bites bring sort of the crazy out in people, and people panic around snakes, I think. And I remember this one case. It wasn't my case, but there was a case where someone there's a whole backstory to how this got popularized, but long story short, some serious injuries happened when people thought that this technique, this really untested technique, would work, and they tried to hook themselves up to their own car battery and rev the engine after a rattlesnake bite to the face. Didn't work out really well, and there's a story behind that too. Now, overzealous ice application is not so cool. It's led to frostbite. For a little while, people were trying to figure out how to manage snake bite. They thought that maybe applying ice would slow the spread, but the tissue is already friable after a snake bite, and so if you add ice on top of that, it's going to do exactly what I told you not to do, and that's add insult to injury. So anyway, so what I recommend is, in fact, the way it was originally recommended was like, just ice immersion. And anyway, that's problematic, and people do that. A little too much ice is not a good thing. Maybe a little ice, like maybe if you have a cool pack, people say it gives them some relief, but just, don't let it get on the skin and freeze the skin. It's not going to be helpful. And this is probably the number one question I get, right? And that's kind of what I'm talking about. People ask me if I or someone is bitten in the wilderness, miles from medical care, And you can imagine any scenario. And every time, the bottom line is going to be, you still need to get to the nearest facility where antivenom can be given, even if it means hours of hiking out or kayaking out or climbing out or whatever, out of deep wilderness. You just have to get yourself to the hospital. And there's some really amazing stories about people who were bitten on very ill opportune days like 9/11. And it's just, it's you still have to get to the hospital. Antivenom is the thing that's going to save you, right? So I imagine there'll be some questions about this. I hope so. And we'll just have to, and sometimes y'all are, studying to be physicians and you're interested in wilderness medicine. And so maybe there's some creative approaches, and everyone's going to have to come up with their own approach. But, if you have some questions in a few minutes, we'll talk about that. And I still think the best first aid, I mean, I sort of speaking a little bit metaphorically or hyperbolically or whatever, but a cell phone or a radio or a satellite telephone, something that's going to help you communicate a way to get yourself out of the deep wilderness. And sometimes it even requires a helicopter, and I used to ride with the sheriff's air rescue out in San Bernardino County, and we used to ride that helicopter, that old Huey, which was fun and kind of scary. We would go up and pull people off the mountains, and it was an adventure when we got to hoist someone off the mountain, sometimes for snake bites. And the cell phones nowadays, you can take a picture of the snake, you can make it your screensaver, and then people can know, if you're unconscious or God forbid, if you're dead, they can see on your cell phone what the cause of your death or your unconsciousness was all about. And that's a timber rattlesnake on that one. But of course, take a picture of the snake from a safe distance. You don't want to have a second bite trying to take a picture of the snake. And by a safe distance, I mean, at least, snakes can strike about, half to 2/3 of their body length. And so if you're, even a big snake is like 5 or 6, maybe 7 feet long top. So if you're more than about 6 feet away, you're probably out of the snake strike zone. You can get a nice, good shot, right? And a lot of snakes have a very distinctive look. I mean, there's certainly, this is a rattle. This is clearly a rattlesnake. There's nothing. And actually, you can tell a lot more even by the picture of this tail. This is actually a Mojave rattlesnake. I can tell just by looking at the way the ring pattern is, and also knowing where the snake comes from. But even baby rattlesnakes, juvenile rattlesnakes have a birth button like this, like a little, it's not like the tail doesn't taper. And so you can identify that that's a dangerous venomous snake. And there's not that many types of dangerous snakes. I think that we can learn about the snakes, and it helps just to like see them and recognize them, helps you recognize them better. And this happens to be a juvenile Southern Pacific. You can see because it's got that yellow on the tip of the tail. I saw a lot of those out in California, a lot of bites by these little snakes. Now, excuse me, just one sec. I'm going to grab a drink of water. That's the nice thing about Zoom. You just grab a drink of water out of your fridge, right? Sorry about that. So where was I? And there's other things that are pretty good about, identifying snakes, like, certainly pit vipers have a pit, and sometimes it's hard to tell, especially with copperheads, or you got to get kind of close. But these are tried and true things to definitely identify pit vipers, like, or rattlesnakes or these things. Other things are really variable. A lot of times you'll hear people talk about, well, out in the sunlight, a rattlesnake's got an elliptical pupil, and this red racer down there, like that's a red. The top image is a red diamond rattlesnake, and the bottom image is a red racer, right? And the pupil's very round, and I don't know, y'all can probably see that from across the room, and sometimes it works out like that, but it's really, really inconsistent. But at the same time, these snakes have a really distinctive look, and I don't know, I think it's not that hard to identify venomous snakes, particularly, rattlesnakes and copperheads are really distinctive snakes, if you ask me. So just take some time, look at them, and you'll and you'll be able to identify them. And there we are, like there's hanging out of a helicopter, pulling somebody off a mountain. That was stuff we used to do, things we used to do, right? Things you may do someday, which is a lot of fun. It's fun hanging around the helicopter. So am I supposed to be admitting these people? I don't know. So what you can do, I've talked a lot about what you shouldn't do or what you can't do, but what you can do en route to the emergency department, in emergency medicine, we're all, and in, lots of resuscitative medicine, basically, and trauma surgery and these sort of things, we're always talking about ABCs, airway, breathing, circulation. You're always going to attend to these things first, of course, while concomitantly ensuring scene safety. You're going to make sure that not somebody else isn't going to be stepping on this snake. Sometimes they're hard to see, they blend in. Maybe they're not rattling at you. Make sure that, you don't have multiple victims. We don't want to turn this snake bite into a multiple casualty incident, although that sounds like fun to me. I mean, it sounds exciting, but not really good for patient care. The other thing is you should remove jewelry and tight-fitting clothing, because what's going to happen is the patient's going to swell, not just in the bite site, but as these toxins circulate through the body, they'll cause vascular permeability to increase, and there'll be there'll be remote swelling on all parts of the body if it's a bad bite. So you're going to swell. Remove the jewelry before you swell up and it's hard to get it off. Maybe watches, jewelry, rings, things like that. And then you mark and time the edge of tenderness. And I'm going to show you, I guess I'll show you, I'm going to demonstrate this a little bit because it helps to gauge how rapidly this thing is progressing. And generally speaking, more rapidly progressive bites or envenomations are more severe, and you're gonna treat them more promptly, more aggressively. And then of course you want to give patients pain medication, and probably the best drug of choice in most of envenomation medicine is fentanyl, because it's short acting and it spares the blood pressure. A lot of times snake bite patients get hypotensive, and then you should position it. And I don't know, there's not a lot of evidence to support which way you should position it, but once antivenom is started, it's definitely prudent to elevate the extremity, because you've already got antivenom going. But I've also found that whenever compartments get a little tight or there's a lot of swelling, some elevation will help reduce that. I mean, immediately, as soon as you elevate it, and also relieve some pain too. So for now, that's what we're recommending until there's better evidence. And of course, transport the patient as quickly, as safely and expeditiously possible to the nearest emergency department where antivenom can be given. And here I am removing my ring and talking about that, because this is what could happen, a lot of swelling. We don't want to get the ring stuck. And then here, okay, so here's a person, this is an interesting case. So, and this happens more often than you would imagine. He's got bites on both hands, right? So how did that happen? You might ask yourself. And it's a funny story. It's kind of a funny story. So this gentleman was mowing his yard and there was a copperhead in the path. And so he used his hand to kind of shoo the copperhead out of the way. And the copperhead bit him on the hand. And so now he's mad at the copperhead. So he uses his other hand to smack the copperhead, which is not recommended, of course, right? So anyway, what I've done here, sometimes it's hard to tell where the swelling is, but it's kind of like an ankle sprain, for instance. If you sprain your ankle, it hurts and it's tender, but it swells more later. It bruises more later. And snake bite is kind of similar to that. Anywhere it's tender is where the is where tissue is being damaged. So you'll see, I wrote a big 1600 on there, and that's where the tenderness stopped. Like I was like palpating along his arm. I was kind of going like, is it hurt here? Is it tender there? Is it tender there? Is it tender there? And then when I got to that point, I said, okay, that's where the tenderness stops. It's not tender anymore here. It's tender here. So I drew a big mark, and that's when I start sort of like watching. And you want to like, you want to see it progressing certainly less than about an inch an hour. And you don't want to see any progression if you can stop that progression by giving antivenom, right? And of course, now we have a couple of antivenoms out there. Man, I have used a lot of Crofab in my day. This was something that we were using since about 2001, and there were studies done. And before that, we were using this Wyeth antivenom crotalidate polyvalent. But then we started using Crofab, and we've been using it for what, 20 years now. And the big revolution between using Crofab and Wyeth's antivenom crotalidate polyvalent is that there's a lot less allergic reactions with Crofab than there were with Wyeth. And with Wyeth, it was kind of crazy because you had to prepare for like anaphylaxis Armageddon every time you gave antivenom. It was really kind of scary. People died from the medicine. It was really scary. So it's not so scary anymore. I was just at a conference last week with almost all the experts in envenomation medicine. There have not been any deaths from anaphylaxis to this medicine since it came out, right? Or from allergic reaction. And there's another medicine too out there. It's called Anavip. So it just became commercially available back in 2018. And the difference with this molecule is it's an FAB prime 2. And I know y'all are studying some immunology. And so if you take the immunoglobulin and you cleave it at a different location, it turns into like a Fab2. So you get like a V-shaped molecule, and that has a different pharmacokinetic or pharmacodynamic. It takes longer for this to get cleared out of the system, so it hangs around and binds and inactivates or interferes with the action of the venom on the tissues, right? So you got Anavip. And the thing that I liked about, I guess that I studied really, I don't know if I should say I liked it because I'm trying to be unbiased, right? But as I studied these, I was actually the first author on the publication that compared this one and this one, right? And I guess the Anavip seemed better at managing late coagulopathy that was associated with the recurrence phenomenon that occurred when these Fab fragments would clear too quickly. And I think I'm probably getting beyond the scope of wilderness medicine. I'm really starting to kind of talk a little bit more about hospital medicine, and we can go into detail about that a little bit more if you have questions. But generally, if you have a coagulopathic bite, probably Anavip is the drug of choice, like a rattlesnake bite. But all the studies that were done for snake bite, for copperhead bites, were done with Crofab. So I don't know. Like I said, I like to talk about what I know, and these are studies I participated in, and the best available evidence says that this medicine is definitely good for expediting recovery after a copperhead bite. It's got a great safety record for a long time, and it reduces the pain medication requirement after snake bite. And this medicine seems to be better at managing and reducing late coagulopathy, and that's something I studied too. So, and that's the other antivenom that was out there for a while. And then I'm going to pause for a minute here and take a because I started to kind of get into some details that may be beyond the scope, I want to pause and give y'all a moment to ask some questions if you want to. And I have a lot more slides. I have like hundreds of slides talking about specific things, and we can delve into those a little more, or I can answer some questions. And if there's no questions, I can show a little video clip. I don't know. And so I want to be a little more interactive. I've been talking the whole time and it feels kind of weird. So look, if y'all have some questions, if somebody would maybe look at the chat and tell me if there's anybody who wants to like ask a question.
Yeah, Dr. Bush, I've got the chat up right now. We got a couple questions.
Okay.
That I can read off for you. So the first question is there a time window for the antivenom treatment to be most effective? After a certain amount of time in the backcountry, if someone is doing okay, are they in the clear?
Yes. So the answer, that's a good question. So the sooner the better, you know, that's consistent with this whole time is tissue. The sooner you get anti-venom on board, the better. But anti-venom has been shown to be effective for days, sometimes even weeks after snake bite. Now you get some diminishing returns, but I've seen things like platelet counts improve, low fibrinogen, which is a marker for coagulopathy. I've seen those things improve, you know, a week out after a snake bite. And like I said, you can still get late coagulopathy in the second week, not so much of a return on your investment there when you give anti-venom, you know, more than a week or so out, but definitely a week out. So the sooner the better, but maybe effective up to a week or more out.
Okay, thank you for answering that one. Our next question was, is it the same antivenom for all species, or are some of the treatments particular to species?
Yeah, and I was kind of speaking to that. So both of those antivenoms that I mentioned, the Anavip and the Crofab, are FDA approved for all North American pit viper bites, and that's copperheads, cottonmouths, and rattlesnakes. So there is a different anti-venom for coral snakes, and I was going to see if y'all wanted to talk some more. We could talk about coral snakes, and of course, there's a different anti-venom for spider bites, like for black widow spider bites, and that's maybe another talk too. But no, I guess the antivenoms are mixed monovalent, but they're supposed to be poly-specific for all the North American species. And I think that for some of them, there's some difference in efficacies. Like I found that Crofab was really effective for Mojave rattlesnake bites. That was in my personal experience. The studies were done with Crofab and copperhead, but for coagulopathy, it seems like Anavip works better. There's little nuances about that for experts like me, but the two antivenoms I mentioned are FDA approved for all North American pit viper bites. Those are called Crotalinae, which is the subfamily, which is inclusive of pit vipers.
Interesting, thank you. To follow up that question, if the patient doesn't know or can't tell you enough to definitively identify a snake, do you take a best guess or administer antivenom based on symptomology?
So that's a good question, and I've learned in my personal practice that it's region specific. So in California, it was kind of like, look, either it was a rattlesnake or it was a non-venomous snake bite. If it was a rattlesnake, it's bad. Okay, rattlesnakes cause badness, and so you know if somebody came in and they had a little bit of swelling, I'm like, well, that's a rattlesnake bite. I had a very low threshold for giving anti-venom, and it was Crofab when I was practicing out there. But if there's a rattlesnake bite out in Southern California, you know, it's either non-venomous or it's a rattlesnake bite, unless it's somebody's pet or something. But a wild snake bite out here in North Carolina, it's a little different, right? So a lot of times people will come in and they're not sure what kind of snake bit them, and so. And you know, maybe in the copperheads, the snake, the swelling is so insidious, and for a while there was some controversy when I first moved here about even giving antivenom for copperhead bites. So, well, now that's pretty much that question's been answered, and patients do better after copperhead bites with antivenom. So, but sometimes you just want to, if they don't have a good description or they can't tell you, you want to make sure there's at least some swelling. You don't want to give this expensive antivenom, and it costs a lot of money to give antivenom. You don't want to give this antivenom for a non-venomous snake bite, right? You want to make sure it's a venomous snake bite, at least a copperhead. And it could be a rattlesnake. And like I said, sometimes there's choices about which medicine I might use for any given snake bite if I knew what kind of snake it was. And everybody has a mobile phone. If you can take a picture of the snake, it'd be awesome to get one, and there's all kinds of ways that you can send that picture around and get it identified,
Great, thank you. And to follow up that with one more question, is
Yeah.
there any adverse effect of giving the wrong antivenom?
Well, I mean, you can have an allergic reaction to antivenoms, right? So that would be bad if you gave somebody an and it's expensive, right? So you could have a reaction to the hospital bill when the patient gets the hospital bill, and if you gave somebody an antivenom like Crofab or Anavip for a gopher snake bite, that's not so good, right? So anyway, I think that's what I'm trying to say is you can have a reaction in terms of like allergic reaction, and you don't want to do that for a non-venomous snake bite.
Great, thank you. Is there a minimum age for administration of the antivenom?
No, not really. I mean, I remember giving it to really young kids. I think that I've given it to a child as young as like 14 months old. And sometimes you have to kind of adjust the volume a little bit, but kids tolerate volumes real well. I mean, you're supposed to mix the antivenom in like a volume. Like if you give somebody like 4 to 6 or even 10 vials, 4 to 6 vials of Crofab or 10 vials of Anavip or whatever, you're supposed to mix it in 250 milliliters. And, say you got a kid that comes in that requires antivenom, you give them a 20 a 20 cc per kilo bolus is like a couple hundred cc's, plus maintenance. It's okay to give them like that bolus, but, even the smallest kids can tolerate that. So, but if you're giving them a lot, you might have to adjust your fluid volumes.
Interesting, thank you. And we have another question regarding which two situations, which would be better. So if you're in the wilderness and you get bit by a snake, would it be better to walk out within 2 hours and get to the hospital sooner, or is it better to stay in place and wait for a rescue?
See, that's just
depend on snake, or does it more depend on individual?
So that really is a case by case. You're gonna have to use clinical judgment about that, and y'all are an audience that's y'all gonna develop clinical judgment over time. You kind of have to think about the risks and the benefits and the alternatives, right, and figure out what the best course of action. I think it's if you have the opportunity to call 911 and somebody can come get you, that's the best thing, right? Because when the medics, my son was bitten by a snake, and whenever medics came to him and they started an IV in the field, and all those things that they do in the field are really helpful when they get to the emergency department, and you can be communicating as they're coming in. And when my son was bitten, I was like communicating, it sounded like it was a bad snake bite. And I was like, well, let's start mixing up the antivenom. So we mixed it up. And when he got on the helipad, I was like I started the antivenom as soon as he got there. Now, I mean, that's a little bit of an exaggeration, but it's true. And so what I'm saying is, for the most part, we have such a good EMS system that they can come get you anywhere, anyhow. That's like the best thing. But I also remember I had a colleague, his name was, anyway, he was he was in a situation where he was bitten by a crate in Southeast Asia, and he couldn't get to medical care himself, and he just languished there while they did like resuscitative measures like mouth to mouth breathing until he finally expired, you know. And so I don't know, it's a tough call. They couldn't get anybody to come get him, so either summon someone out or you gotta get yourself out, and every scenario is different. If you have something specific that happens to you, you know, let me know. Tell me your stories, because I want to have some more stories I could tell people, you know. The guy I'm talking about was really interesting account. His name is Joe Slowinski, and he was in Thailand, and he was bitten by a crate. And it's just, I don't know, it was really hard. It was a tough day to get him out of there. They couldn't get anybody to get him out. So, but that's pretty special circumstances. Most of the time, you can call 911 and get medical care.
Thank you. We did actually have one story here in the chat.
Okay.
An individual stated they had a case here in Pennsylvania with a C. horridus, and the patient had 18 vials of Crofab, and he wasn't responding well to it. So they administered 11 vials of anti-vid. He recovered very quickly. Have you ever seen any other cases where both FDA antivenoms were used with success?
That's interesting. You know, I remember whenever Crofab first came on the market, you know, and we were still like transitioning away from YS anti-venom crotalidate polyvalent. And before Crofab was on all the shelves, you know, sometimes patients would be treated at the outside facility with YF, and they come to us and we're like, well, can we mix this? And we ended up mixing it, you know, and we ended up giving them both. Now there's no studies about that, you know, that's not evidence-based, but that sounds like a really interesting anecdote, and there'll probably be a lot more cases like that as time goes on. You know, different facilities may have different stocking practices, and so there's still a lot to learn about these medicines. There's always something to learn about it. Great questions.
Thank you for responding to those. Those are all the questions we have currently in the chat. We do have a few more minutes if there's anything else you wanted to discuss.
Okay, what I was thinking about doing, if we had a little extra time, is I saved this video. I queued up this video, and I want to show you a quick video, if I may. And if y'all, you know, if people sign off or whatever, and I'll answer questions after the video because it's going to go over. I think the video is like 7 or 8 or 9 minutes, and we're out of time. But the video, it's kind of basically when we were shooting Venom ER, there was some archival leftover footage, and there's a camera like over my shoulder. And so it kind of gives you the feel of what it was like to treat these off the scale snake bites. So I'm going to show you this video, if that's okay, if we have time for that. Is that all right, Seth? Okay, I'll show you the video. If anybody signs off, I'm not going to be offended. If anybody's still on and has questions, I'll hang around a little after that too, okay? Because it's really graphic. It's amazing. I'll show you. Here, let me in the show and show the video if it works. And I just want to make sure the audio is going to work. We tested it earlier, but can y'all hear this okay? Okay, I'm going to zoom it up and play it right now. And it's 9 minutes.
Dr. Bush, are you still there? I think we lost you.
I'm here. Can you see me?
Yes, I see. The screen is just, someone else tell me if the screen is not frozen for you. It's frozen on my end.
Okay.
Yeah, the screen is frozen for me on the PowerPoint as well.
Dr. Bush, do you want to unshare your screen and then try again? It looks like it's just sticking on the PowerPoint.
What is it sticking on? Is it sticking for everyone? Okay.
Yeah.
How far did y'all get?
So far, I still see your PowerPoint. It just says questions so far.
Oh, I see what I know exactly what happened here. I know what I did. Let me try this again. I'm so sorry. Stop share. and then I'm gonna share it again. Can y'all see my screen? There should be a copperhead on your screen if you're seeing my screen.
Yep, we see the copperhead.
Okay, so let's find this again. Okay, I'm sorry. Let's try again. I'll try not to mess it up this time.
Looks good.
Okay. Audio's okay?
Audio's working too.
Percent, 2%, and 160 sucks. No,
Okay.
no effect.
You want to check now?
Where's my
Dr. Bush? Yeah. Check here. Check the breath sound. Here, I got it.
Did you get the form from what's her name? Oh, Linda? Okay, well, I don't have anything
Is
to.
there
Put
anything?
my rail up, please.
You want to take the tube now?
96 stat or 3%.
Yeah, he's okay. He's okay. They were good. Okay.
You guys want a BP machine so we can check the blood pressure? Size 8.
Where's his
Maybe a little more on the right than left.
The IV bag is right here.
Yeah.
It's gonna be a Benadryl IV left. Oh, right. The IV on the left hand.
Okay, tube is in. Okay.
Benadryl's in.
Thanks, that would have been the rest of the nightmare if the tube was somewhere wrong.
She doesn't have a groove. We don't even
No.
turn it.
It's a little, we pulled the ice pack off.
Probably left it on the right. You're probably gonna.
When you first saw him, if you'd seen a profoundly
28.
person just going up, and sitting there kind of just fat, that's what it was like, the
We got it.
modeling. And the,
I'm fine.
paper.
Yeah.
You want to paralyze him with faith?
Yeah, we don't care about that.
Good luck.
You already were.
Just wanna put this on a finger. I need a alcohol.
What numbers on the side of that is tape?
No.
We're gonna get a raptor. It's a rattlesnake. This is another kind. Right here. He's 44 years old. 120 pound, heart rate's 110.
What's your name now?
His name is Ross.
Definitely needs to be tubed. Let's bring him over. We're gonna tube him here. All right. We're gonna help you. We're gonna help you.
Leave this on as best you can, all right? We have it dominating the sun. Working in the yard, snake bites with a pointy finger. Not so. Adam off the frozen route. We're gonna help you breathing, all right? Double face. You got there.
You got your tubes, you got your blades. Start with 7. You got medicines ready? We're ready to go ahead and push those meds. Hang on, you gotta keep it on. It's oxygen, okay? Keep it on. Hey, we got it. You got to.
All right.
How many lines? Hey, how many lines do you have? Do you have one line?
One line is definitely patient.
Okay. Is it working good?
Yeah.
Okay.
We're gonna need some help.
Hey, you gotta push the meds.
Get the accommodate.
Push socks. Push whatever you got.
On the right side.
You gotta push the meds.
Where's the IV?
On the right arm. Right arm. Right arm. Right arm.
Right arm.
Hey, we can use a hand here, please. We can use a hand to keep him.
Here. Hey,
Cushy.
that's sucks. Good. 200 sucks.
Cushy. Accommodating sucks.
Okay.
What you pushing? I'm pulling him up. I don't want to get bit. I think we're going to be going surgical. I need a better mask, whoever's not doing something.
Need a BBM.
Bag valve mask would be great. Can somebody give me some betadine, please?
Yep.
Okay, let's go. Let's get oxygen back on him. All right. Sean, what kind of surgical airway do you want?
All I want is a 6.0 ET tube.
Okay.
I got everything else I need right here.
You got one?
Okay, well, we're going surgical. Let's bag him back up and we're going surgical. Let's go ahead and somebody mix the crofab and start to give it.
Are you able to?
Yeah, that's in. That's in. Okay, watch out. I'm gonna blow this up. Let's see if that works. Nice and quiet.
Let's suction through that. Or go.
Sat's 100%, and we've got the crike in.
Alrighty, thank you.
She's got a lot of edema. Okay, that looks like where he might have tried to cut right there, try to suck the venom out. It's a Southern Pacific rattlesnake.
Oh, that's suspected, huh?
I can't believe that little guy did that.
Well, I guess he's just hypersensitive to it.
Hey, Ralph, there's some question about the kind of snake that bit you. Was it this rattlesnake? For sure, it wasn't an exotic or anything. It was a rattlesnake, for sure. Okay.
We need to check.
I have the vitamin K right here.
Okay, I'll give that to you. I'm just gonna.
Take a look here.
Well, I'm just trying to talk to him right now.
Yeah, I can see a puncture wound here. Got a lot of swelling in the hand, going up the arm. Still twitching all over. Can you see the fasciculations here?
Where? They're out on his leg.
He's got them on his leg. Yeah, that's this is bad. This guy's really sick. This is the worst snake bite I've ever seen.
Wow. Your teeth gone.
As well as, of course, they think he may have asked further, they said he had long legs.
All right. Can y'all still hear me there, Seth?
We still hear you.
All right. Are there any questions after that?
Can I just ask, did you ultimately find out if it wasn't the rattlesnake, or did he get bit by something else?
Oh yeah, no, these were all rattlesnake bites in Southern California, and just really, really bad snake bites, you know. And there's 3 different patients. All 3 of them were probably bitten by Southern Pacific rattlesnakes, just judging on the location of the bites and everything and the way they presented. But yeah, just 3 really bad bites. Now, all those patients survived. They did well. But they were really, really bad when they came in, you know.
I have a couple questions here in the chat. If you have time for 2 more.
Yeah, I have time. I don't, yes, I have time. Now I think I can see this chat too, so.
So our first question was, to your knowledge, what is the highest number of ProFab vials given to one patient? The individual asking this question said, I've heard some very high numbers, and at what point do you decide the antivenom isn't working and to try something else?
Well, you know, and I can quote you some high numbers too, you know, and I remember back in the early days when we were seeing patients like that last one with the muscle movement, the myokymia, some people call them, some people say fasciculations. We you know, we use a lot before we realized, hey, like I think we gave that guy about 60 vials of Crofab. And this was very shortly after Crofab was just available on the market. And the myokymia did not, those fasciculations did not respond to the Crofab. He just kept, every time we would let him, you know, the sedation wear off, he would still have fasciculations. And so we kind of concluded, and I talked with some of the folks, some basic science folks like Richard Straight, and we talked about how probably those are small basic peptides that are causing those muscle movements, and they don't really generate a good antibody response. And therefore, you know, those, you know, antivenoms don't neutralize those toxins very well, is basically what we're trying to say. And I also, but I think there's also a message in this too. You know, when you start getting into mega doses of antivenom, there's kind of like, it's expensive, and just make sure you're talking to someone, because, you know, an average dose of Crofab is probably about 14 vials. You know, when you start getting beyond about 12 or 18 vials, I hope you're talking to somebody that's had a lot of experience treating snake bites, like somebody from one of the poison centers that are experienced treating snake bites, like Rocky Mountain Poison Drug and Drug Safety, or you know, one of the Arizona programs, or California. I just think that, or some, you know, an expert like myself, if I'm able to be involved in that, there's just, you can probably give too much, you know. I mean, maybe it's not necessary to give quite so much, you know. Make sure we're targeting something that's going to respond and giving the antivenom appropriately.
Great, thank you for that piece of advice. This was actually a spider question, if that's okay with you.
Yeah, absolutely. In fact, I'll tell you, go ahead, ask your question.
Oh, sorry. This individual asked, out of the last 100 Black Widow spider bites you've seen, how many were serious enough to require antivenom?
I didn't quite catch the question, but it sounds like, what was the question again?
How many Black Widow spider bites that you see have been serious enough to require antivenom?
Okay, I hear you. So that's a good question, and I have a whole nother talk on spider bites, and I'm going to be giving that at the Houston Venom Conference, which is, I think that's going to be in June, if I remember correctly. But Houston Venom Conference, look it up. We're going to be talking all about spider bites. I'm going to have videos. I'm going to have lots of cool stuff, pictures of spiders and bugs. But to answer your question as succinctly as possible, I think that, you know, I've given the anti-venom for patients that have like pain that's refractory to standard, you know, doses of pain medication. If it, you know, refractory pain or a complication related to spider envenomation, like, well, you know, like if somebody's having, well, I mean, one complication that comes to mind is you can get priapism from spider bites, and that would be a complication that I would give anti-venom for. You know, if somebody's having a lot of chest pain or refractory pain is a good one. And, you know, if you give the Merck product, you know, just be prepared for really bad allergic reaction. If somebody anaphylaxis in front of you, then I think you can manage it and you can save that person, you know, because every emergency physician, you know, worth their, you know, worth anything, worth their license, can manage or you know, can manage anaphylaxis. We all know how to do that, especially if we recognize it and see it right in front of us. We can manage that. Yeah. So sorry about my dog. I think that, does that answer your question? Oh, I wanted to say one more thing. There is a new anti-venom that I kind of helped develop by enrolling patients in like phase 2 and phase 3 clinical trials. It's called Antiwido, and we think that that's probably going to be on the market somewhere around 2023. My dog's going nuts. I'm sorry.
No problem. Bry, who answered the question, did say yes, that you answered his question well enough.
Good.
So thank you. And thank you for your talk. I thought it was very informative myself. That's all the questions we have in the chat. So I just want to thank you and say we really appreciate you being here. And if Seth doesn't have any additional comments, I think we'll wrap it up for this evening.
Just wanted to say this has been phenomenal. Thank you, Dr. Bush, so much for your time and for sharing your expertise.
Well, good. Well, hey, let me know if I can come back and talk about spider bites or scorpion stings or marine envenomations, or if I can come in person. I would love to be there in person next time once this pandemic blows over, right?
We're actually all across the country, so I don't know if we'll ever have an in-person session or not. But certainly would love to be in touch and have you on again to talk about some more things.
Well, in that case, I'm glad we were able to meet this way. If everybody's spread out across the country, look, please give me some feedback. Let me know what you thought about the talk. Reach out. I think I gave my contact details. I'm on Facebook and Twitter and all that sort of stuff. And yeah, let me know what people think. If there's something I can do to improve, or if you have any other questions, please let me know. Okay.
Great. Thank you so much.
All right. Thank you all so much.